Right, today we're going to talk about some random derm path cases that I came across recently. These are kind of bread and butter cases, what you might see in a normal day of sign out of skin biopsies at the microscope. So the first case that we have here, this is a seborrheic keratosis. These are kind of benign keratinocyte proliferations. They usually occur on older people and have this kind of stuck-on appearance. Usually they're dark in color. And microscopically, there's a variety of different patterns that you can see. This one's kind of the acanthotic pattern. The epidermis is really thick. Look, here's the normal epidermis. You can see the thickness of it right there. And then here's the lesion. Look at how thickened, how elongated the Reedy ridges are. They're really thick and fat and filled with cells. And the Reedy ridges all kind of interconnect together as they come down. Let's find our arrow here. See, they come down and they kind of interconnect and kind of spread along, merging with each other. And what is left behind are these cystic spaces that are filled with, usually with loose orthokeratin. So this is a dead keratin like you would have up here in the corneal layer. It's the same stuff that you have that's accumulating down here. And these are not really cysts, these are pseudocysts, because if you cut deep enough, what will happen is these cysts actually connect up to the surface. So this is kind of a funny artifact of the way we cut through and section the tissue. So these are called horn pseudocysts. So you get a thickening of the epidermis, and it's made of these kind of small, some people say basaloid. I don't really like that term personally because I think these look quite a bit different than basal cells, but they're kind of small keratinocytes that are usually very uniform and monotonous. And they often have pigment in them, and that's why these lesions look dark brown clinically. You can see that pigment there. That's melanin pigment. Now remember that melanocytes make melanin, and then they kind of feed it to their neighboring keratinocytes. So just because these are brown doesn't mean that they're actually melanocytes. They're actually keratinocytes. And you can see this little halo that they have. If you have a little halo with a naked nucleus in the middle, that's a good sign that you're probably dealing with a keratinocyte, not a melanocyte. All right, so this is a seborrheic keratosis, and these are benign. Sometimes they can clinically look like melanoma or other melanocytic lesions. Here's another cut from the same lesion, and look again, those thickening of the epidermis and these horn pseudocysts that are filled with that orthokeratin. Now, if you start seeing a bunch of dense pink keratin with retained nuclei, parakeratosis, in the middle of these pseudocysts, then you have to stop and think about the possibility of a subtle squamous cell carcinoma, because squamous cells, they tend to make little keratin pearls, but instead of it being loose orthokeratin like this, it usually has parakeratosis in the middle. When seborrheic keratoses get inflamed or irritated, though, they can also make parakeratin down in those horn pseudocysts. So you don't want to use that as a hard and fast rule, but it is a thing that's worth considering. And another thing that I think is useful about seborrheic keratoses, let me get in focus here, is that they usually kind of grow up from the surface of the skin. They kind of push up. And that actually, if you can kind of draw a straight line across the bottom of the lesion most of the time. See, if we go up to the top piece, we can do the same thing. The lesion looks like it's growing down, but it's actually not. It's actually pushed up like a little dome above the skin, and you can draw a straight line across the bottom. So seborrheic keratoses usually do not infiltrate down into the skin. They kind of push up. See, again, the same thing on the third piece here. You can draw a straight line underneath. So thickening, a thickened lesion that's kind of arising from the epidermis, made of bland, small keratinocytes, often with melanin pigment. And then horn pseudocysts, that's a seborrheic keratosis. Okay, let's do the next case. We'll make it the right side up. Now this lesion's so big that we can't actually even put the whole thing underneath the microscope. But let's look and see if we can figure out what this is. It's a lot bigger than the previous case, and all that bright red stuff, that's keratin, just like the last case. It's just a little more dense. That's why it looks so red. And also, I think this slide may have just picked up some more of the eosin stain. But look, if you see the epidermis is thickened, the Reedy ridges are really elongated and fusing together, and what you're left with are these horn pseudocysts again, these kind of pseudocystic areas in between. And look, when you get a certain cut here, you can see that those cysts aren't really cysts at all. They open up to the surface. That's why we call them pseudocysts. And here it almost looks a little bit warty. So you can sometimes think about a verruca or a wart with this lesion. But look right here, you get kind of a straight line across the bottom. I think this is another example of seborrheic keratosis. This one is very irritated and inflamed. It's got an area over here that you can see is really thick and has got a lot of lymphocytes, a lot of inflammation. So sometimes these lesions get really inflamed over time, and when they do, they can sometimes mimic squamous carcinoma clinically. And look at all that pigment there. This is why they look so dark. Not only is the pigment in the keratinocytes, which you can see up here. There's pigment and keratinocytes. But there's also these little branchy, thin dendritic cells. Dendritic means it has little branches or arms. Sorry, let me adjust the light a bit. And those are actually melanocytes. Those are pigmented melanocytes that are kind of dendritic. You can tell because of their little branching processes. So melanocytes usually aren't very darkly pigmented, but sometimes they are. So there's always exceptions to every rule in dermatopathology. And sometimes dendritic melanocytes get caught up in the middle of a seborrheic keratosis, and they further contribute to the dark color. And also when seborrheic keratoses get inflamed, they often will do this. They'll drop melanin pigment out of the epidermis and into the dermis. And then macrophages come and eat that up, and so those are called melanophages. So if you see real dark cells in the dermis, usually they're going to be melanophages, which are pigmented macrophages that are eating up the melanin. Usually they're not melanocytes. Again, exceptions exist for all of these rules, but that's kind of a good rule of thumb. If you see real dark cells in the dermis, most of the time they're melanophages. So going back to lower power here, again, even in this area that's more inflamed, you can see it's a thickened lesion arising from the epidermis. You've got horn pseudocysts, which is a really useful clue from low power. And again, when they look kind of darker blue or purple, sometimes squamous cell carcinomas can have this same kind of pattern. So go a little closer and look, but I still think that the cells here are very uniform and monotonous looking, and I think that's good. And sometimes they can get a little bit of atypia and some mitotic activity when a seborrheic keratosis gets really inflamed. And you see, when you get irritation or inflammation in a seborrheic keratosis, sometimes the horn pseudocysts do begin to produce parakeratin. So again, I always look a little closer when I see that just to make sure I'm not missing a squamous cell carcinoma. But in this case, I think what we have is just a very big, robustly irritated and inflamed seborrheic keratosis. It's a very large one, and I can imagine that if I had that on my skin, I would want it to be removed as well. Probably very uncomfortable. All right. And these lesions don't look really pretty on someone's skin, but I think they're actually quite beautiful under the microscope. And I guess that's why I'm a dermatopathologist. All right, so here's another case. Again, this is just kind of a routine bread and butter derm path case. Here we have, again, we're at the lowest power, and I still can't fit the whole lesion under the scope, but you can see how this is kind of a dome-shaped lesion that protruded from the skin. And the dermatologist said it was flesh-colored or skin-colored and kind of soft and fleshy to the touch. You could push in on it. It was not firm. And you can see this is normal dermal collagen here, this kind of bright pink stuff. This is the type 1 collagen of the normal dermis. And here's a sebaceous gland and hair follicle. Here's a sweat duct. And then over here, you can see that normal dermal collagen goes away and the dermis changes color. It becomes more spindled, more cellular, and it's got a kind of lighter pink color. And if we go in closer and look at those cells, we'll see these are not normal dermal fibroblasts. These cells look a little different. So these cells are bland cells that are kind of thin and elongated. So we call those spindle cells. And some of them have kind of a kind of curved or crooked nucleus. Like the nucleus is kind of elongated, but it looks kind of bent or buckled or curved. These are Schwann cells, actually. They're Schwann cells, and they're mixed together with some other cells like fibroblasts. And this is actually a neurofibroma. And neurofibromas have these bland spindle cells. They have really pale collagen that they produce. And they often will make a little bit of bluish mucin or myxoid background, which is hyaluronic acid. We don't really see that in this case, but you can often find that. And this case particularly was a nice one because a lot of times in neurofibromas what you'll see is a background population of mast cells. And let me see if I can get them to show up here on the video, because I thought they were actually pretty nice in this case. I'm going to adjust the lighting a little bit here. So this little guy right here in the middle that looks like a little fried egg, that's a mast cell. And you can't really appreciate it on the video, but it's got a very kind of delicate granular cytoplasm. And I think that's really helpful to detecting mast cells. Here's another mast cell over here, another mast cell down here, mast cell there. So mast cells can be seen in lots of things, but they often kind of are scattered throughout the background of a neurofibroma. And again, look at these nuclei, they're very bland. Some people say that Schwann cells are pointed at one end and kind of blunt at the other end, that they look a little bit like a sesame seed, like those little seeds that you get on on a bun of a hamburger. And I kind of like that that analogy. One of my mentors, Mark Edgar, taught me that, and I think that kind of works pretty well. So these bland Schwann cells, this kind of fine, light pink collagen background, sometimes with myxoid change. This is neurofibroma, and the mast cells are a nice little clue as well. And I think this one had another feature that was useful. Let's see if I can find it now. Well, once you're recording a video, then you'll never find it. So let's see. Here we go. So right here in the middle of the field, and again, let's see if we can get it to come up and show up nicely. This little pink bundle right here, that's a little tiny nerve twig, and here's another one. So those are little tiny nerves that are in the middle of the neurofibroma, and that's normal. Neurofibromas normally have nerve twigs in them, whereas schwannomas, for example, are made totally of Schwann cells and don't have any nerves in them. So this is a little nerve here, that's a little nerve here, and that's a little nerve here. And you can see a little touch of that light kind of bluish color around it. That's mucin, hyaluronic acid. You often find that around normal nerves, but also in neurofibromas, I feel like that tends to get a little accumulation around the nerves. And then here's a little mast cell over there too, which I can't quite get in focus, but I promise it's there. All right, so that is a neurofibroma, and people often sporadically get neurofibromas, and it's of no worry or concern. Of course, people with neurofibromatosis get neurofibromas as well, and the most important neurofibroma they get is a plexiform neurofibroma, and usually those are deeper. You sometimes see them in the dermis, but most of the time they're going to be deeper in the subcutis or the deep soft tissue. So that is a neurofibroma, and usually from low power you can recognize these just from the fact that it's this kind of pale color of pink, and it's a spindle cell tumor that's pale and filling up the dermis and kind of replacing the normal dermal collagen. One kind of potential pitfall is there's a sarcoma called dermatofibrosarcoma protuberans, DFSP, and it can have cells that look a good bit like the cells of a neurofibroma, very bland. Even though it's a malignant tumor, it doesn't have atypical cells. It lacks the nuclear pleomorphism and atypia that a lot of other sarcomas have, and it can look an awful lot like a neurofibroma. So I think that tumor usually stains with a stain called CD34, and the pitfall is that neurofibromas, a lot of people don't know this, but they also often stain strongly with CD34. So if you do a CD34, you could potentially be confused, but if you use an S100 protein or SOX10, both of those are very good neural markers, and they will very nicely stain neurofibromas and be totally negative in dermatofibrosarcoma protuberans. So that's the little trick to make sure that you don't confuse neurofibroma with DFSP, because neurofibromas sometimes can go down and entrap, sorry, I'm getting out of focus a little bit, can sometimes entrap adipocytes like this, and that's what DFSP does. So it's an easy mistake to make if you're not familiar with that mimicry. And an S100 stain will easily keep you out of trouble if you have any doubts. And oh, here's the area I think that had even better. I can see the mast cells already. There, see those little pinkish purple fried eggs there? Makes me hungry for breakfast. So there, these little cells right here, and you can see the little light pale granules. They're not the bright orange granules of an eosinophil, they're these little fine granules, and they contain things like histamine, and that's what mast cells do. If they get activated, they release those granules, and it causes swelling and leakage of blood vessels and stuff. And that's another mast cell, another one. So a really, really beautiful example of a background mast cell population that's kind of scattered throughout a neurofibroma. And again, look at the nice buckled or bent nuclei. I really like that someone took a little spindle cell and grabbed it and kind of twisted it into a little crooked bent shape. And that's a really nice feature. When you see that little bent cell like that, that's a really good feature to suggest that you're dealing with Schwann cells. And Schwann cells are one component of a neurofibroma. So there's neurofibroma. So this case, here's a biopsy of skin, and look, the dermis, instead of being the pink color it's supposed to be, is this blue-gray color. The entire dermis has changed color, and the reason for that is that all of the normal collagen, or almost all of it, that used to be here, so you can, let me find a little area, that's the color the dermis should be, that little bright pink color right there, type 1 collagen. But instead, this dermis is totally replaced with blue, gray, disorganized, tangled up elastic fibers. So this is called solar elastosis, and that indicates that this person has probably been out in the sun all day, every day of the week for many, many years. It takes a long, long time to build up this much solar elastosis. I mean, the entire dermis is basically replaced with it here. So this is probably an older person who's spent lots of time in the sun. And the clinical impression was that maybe this had like a hard kind of nodule in the dermis, and they wondered if maybe there was a foreign body, like maybe they had gotten, cut on something and a little piece of metal or glass or something broke into their skin. And I wondered if that might be the case. Right here, the epidermis looks kind of thickened and reactive. There's some scarring and blood in the dermis here. And so I thought maybe it was a foreign body that we just was underneath the shave biopsy. And then I saw an extra piece here. And now we actually can get to a diagnosis. So here, there are some kind of blue little basaloid cells on the outside, and in the middle, there's pink keratin. But this keratin's kind of special. It doesn't just look like loose flakes of keratin. It actually looks like you can see the outline of individual cells. Sometimes it's hard. Let me put the condenser back up so you can see. See, you can see like a shadow or a ghost outline of dead keratinocytes. And those the same kind of cells that are over here, those cells have kind of died off and converted into these sheets of ghost or shadow cells. And these are a very, very characteristic, very useful clue to the diagnosis that we're going to make here. And the other thing that you'll often see in this entity, see here's more of these kind of shadow or ghost cells. More of them still. And then the other thing that you're going to see are these areas here, blue basaloid cells. They're very blue because they have nuclei, but little cytoplasm. And the blue basaloid cells are kind of converting into these areas of sheets of ghost cells. And this right here, this one picture, this is diagnostic of pilomatrixoma or pilomatrixoma. You can put either a C or an X in that word, whichever you like. And pilomatrixoma is a benign hair follicle tumor. Sometimes it's kind of cystic, and it can be hard and firm because it often calcifies. So that explains clinically why it kind of looked like a firm nodule that might have been a foreign body. But what you have is varying amounts of these blue basaloid cells, which are kind of what these are. These are called matrical cells. They're recapitulating or kind of imitating the kind of cells that you see in the root or bulb of a normal hair follicle. And what normal hair follicle matrical cells do is they turn from blue cells like this and kind of die off and become dead keratin, and that dead keratin organizes into a hair shaft. That's the normal process that happens in a hair follicle. And that this tumor is trying to kind of recapitulate or imitate that process. It's just not doing a very good job at it. So instead what you get are these blue matrical cells, and these cells are usually uniform. They might have small nuclei, but they don't usually have marked pleomorphism or atypical mitoses. They may, however, have quite a few normal looking mitoses, and I think that that's sometimes because they're blue and cellular, and because they often have a lot of mitotic activity in them. See, mitoses can be very brisk. Here's one, there's another one there. Because you can see so many mitoses, if you're not familiar with this tumor, you can get very scared and worry that it's malignant. And there is a malignant form of this, but it's quite rare. And usually you can have marked atypia and really infiltrative growth, which we can't really see here because this is fragmented. And these are the sheets of kind of ghost or shadow cells. So the blue basaloid cells and the ghost and shadow dead keratinocytes over here, pilomatrixoma. And this one's got even a little bonus. These little red things, these are called trichohyalin granules. And again, that's a finding that you see in the inner root sheath of a normal hair follicle. So if you're really into derm path, you'll appreciate that and think that's cool. And it makes me happy when I see those, at least. So really nice example of pilomatrixoma. These are most common in young kids, often in the head and neck area, but they can be seen in people of all ages, and even this person who is older, totally fine to have pilomatrichomas. I see them in older adults all the time. And anyway, this is a really nice example. And if I see the blue basaloid cells and the matricals, and the shadow or ghost cells, that's really great. But sometimes all you'll see is kind of a granulomatous reaction and just some fragments of these shadow or ghost cells. And for me personally, I'm happy if I just see some of these ghost cells, I'm happy to say that it's suggestive of or consistent with a pilomatrixoma, because it's a very characteristic finding to see these shadow or ghost cells. Very, very unusual to see quite this pattern in anything else really other than a pilomatrixoma or a couple of similar entities. Okay, let's go to the next case. Here's a shave biopsy of a patient with itchy bumps on their trunk. And I really like this entity. I think it's really kind of a nice, easy thing to diagnose microscopically, and has very distinct features, and it's kind of cool looking. So I will show it here. It's a good example of what we call Grover's disease, or transient acantholytic dermatosis, which is why we call it Grover's disease, because that other name is too long for most people to use or remember. And Grover's disease is a nice example of two different microscopic patterns, and it's good because you can learn these patterns, and there are some other diseases that have this same pattern. One thing that we see here is the normal epidermis. Let me get in focus. Apologize for the lighting issue. The normal epidermis, the reedy ridges are kind of elongated, but what you see starting to happen here is that the keratinocytes are falling apart. They're losing contact with their neighbors and leaving white space in between them. And they're starting to kind of round up and get this dense pink cytoplasm, that dense pink color, so that's called acantholysis. Acantholysis means that the spiny layer of the skin, the desmosomes, are losing contact with one another, and the cells are kind of rounding up and balling up, and that's what acantholysis is. And you can see here that the basal layer is still stuck down here onto the dermis, but all of the cells above have kind of detached and broken loose. It's almost similar to the pattern that you see in pemphigus vulgaris, and in fact pemphigus vulgaris is another disease that does have acantholysis. So here we have acantholysis, and then we also have another thing that's happening up here, is that those acantholytic cells, they're breaking free, and they're dying and turning into these dense, bright pink little bodies that have dense, purple, dark nuclei. And this pattern is called dyskeratosis. It's kind of a funny pattern of the cells undergoing cell death, and the nuclei get real crunched up and purple, and the cytoplasm gets really, really bright pink. And so the acantholytic cells, they get called two fancy names. If they're long and thin and look kind of like parakeratosis, people call them grains, like they look like a grain of wheat or something. And if they're more round like this, people call them corons, which is the French word for round bodies. I'm recording a video. The French word for round bodies. And so corons and grains are these little cells up here, and that's dyskeratosis. So acantholysis plus dyskeratosis, and a patient that has little itchy bumps or papules on their trunk is great for Grover's disease. And the other, there are a handful of other diseases that have both acantholysis and dyskeratosis. The other one's called Darier's disease, which is a genetic syndrome and has a different distribution, large plaques often on the trunk. And another disease is called Hailey-Hailey disease. Hailey-Hailey disease has a lot of acantholysis, but doesn't have as much dyskeratosis usually. And it usually involves kind of the fold areas like the groin, around the neck, or underneath the axilla. It's also a genetic disease, but has lots of acantholysis. And then pemphigus can have acantholysis as well, but it's due to an autoimmune reaction, autoantibodies that are attacking the desmosome spines in the spinous layer of the epidermis. So that little combination, this little small lesion of acantholysis and dyskeratosis, beautiful example of Grover's disease. Grover's disease often gets inflamed and often has some scattered eosinophils in the dermis under it, and that is part of the reason probably that they're kind of itchy. So if I see a little focus of inflammation in the dermis with some eosinophils, I'll often look carefully in the epidermis or maybe cut deeper levels to see if there's a little papule of Grover's disease there that I haven't seen, because sometimes they can clinically mimic a cancer. All right, here's the next case. Well, this is a really nice example. This tall lesion here has a lot of keratin on top of it. So when you get piles of dead keratin on the surface of a lesion, we call that a cutaneous horn. And clinically, it looks like a little horn growing out of someone's skin. So a handful of different entities can make horns. Warts can, squamous cell carcinoma, actinic keratoses. And the only way to really know what's making the horn is to do a biopsy and let us see what kind of living cells are underneath it, giving rise to the horn. So here you can see that that's the skin surface down here. And this lesion is growing straight up from the skin surface, making a single papule. And on the surface, it does look a lot like a wart. And clinically, they were thinking it was the wart. It's on the face of a middle-aged patient. And it's got these kind of elongated tips here, look, fingers that are sticking up. So we call that papillomatosis. And on the tips of those, we see parakeratosis, little nuclei retained in the corneal layer. And then other areas look more like orthokeratosis without as many nuclei, so that's good for a wart. There's also some little foci of blood or serum in the corneal layer. So those little hemorrhages, we often see that over top of warts. So a lot of things here to make you think of wart. But when you actually go down to the base of the lesion, we see something interesting. We see this kind of smooth, protruding, bulging border that's pushing down into the dermis, and it's made of pale, almost clear cells. And these cells are pale because they contain glycogen, sugar, that dissolves and washes away during our routine processing and leaves the cells looking like they're kind of almost empty. And then around the outer surface, the outer layer of cells are kind of lining up into a little row. We call that palisading, kind of like the palisading you see in a basal cell carcinoma, just not quite so dramatic. So that little palisading around the outside, and then these clear or pale cells in the middle of the lesion bulging down, and then a warty surface, all of those things come together for what we call a tricholamoma. Tricholamoma is a benign hair follicle tumor. It often looks a lot like a wart clinically. And in fact, some people believe that these really are a variation of a wart. And there have been some studies that show that they have a human papillomavirus, and other studies show that they don't. So I think there's some debate over that. Some people believe they're warts that are kind of involving a hair follicle, and that's why you're seeing this, what this area here is with the glycogenated cells. This is basically mimicking the outer root sheath of a normal hair follicle. So other people believe these are benign follicular tumors. Whatever you believe they are, or whatever you want to call them, it's good to recognize because occasionally these can get confused with other cancers, both clinically and microscopically. But I think finding that little palisading and then the clear cell in this kind of bulging or pushing border is really useful. And patients who have multiple tricholamomas, sometimes you see that in the setting of Cowden syndrome, which is a genetic syndrome that involves the P10 gene. So patients with multiple facial tricholamomas, think of Cowden syndrome. And Cowden's is associated with a variety of internal cancers, so it's a good syndrome to know about. When you just see one lesion, I don't get very worried about that personally. All right, here's another little bump that was on someone's face. This was thought, I think, on the nose, and they thought this was going to be a basal cell carcinoma, maybe clinically. A basal cell or maybe a wart, something like that. And what you can see is that the epidermis is a little thickened here and has a really thick purple granular layer. And the corneal layer is thick and it has this little dense line of pink there. So when you get a really thick purple granular layer in this kind of thick light or dark pink zone right over it, we call that lichenification. It means that someone has been scratching or picking or rubbing at the skin, and the skin is growing thick and is starting to look like the skin you see on the palms or soles, acral skin. And that's kind of a defense mechanism. The skin's making itself thicker to protect against the irritation. But the reason that this person is rubbing or scratching at their skin is not because the problem is the epidermis. The problem is actually here in the dermis. The dermis has this dense pink collagen. So there's not much normal dermis here, but this is a very dense pink collagen deposition in the dermis. And there are these dilated, kind of branchy looking blood vessels. And then if you go closer, you can see that embedded in the collagen are these larger kind of hyperchromatic cells. Great example. Right here, they're kind of large, they have a lot of cytoplasm, and they're kind of star-shaped or stellate or triangular shape, whatever name you like for them. They kind of have multiple little branchy arms stretching out. And some of them right here even look kind of like a nice little triangle. See, these are very triangular, or what we call stellate cells. So dense collagen in the dermis, these kind of stellate cells, these are actually kind of funny fibroblasts is what these are. And then dilated vessels, those three things together are what we call an angiofibroma or fibrous papule. These usually occur on the nose, but can also occur in other places. And they clinically often mimic basal cell carcinoma. So a really important thing to recognize, these are common. You'll see them on biopsies all the time. And this is a really beautiful example. And these little stellate cells sometimes can get kind of atypical looking and make people worry for something atypical or malignant. And my mentor, Doug Parker, who taught me DermPath in fellowship, he actually said that he thinks these little triangular shapes look like the little Star Trek insignia that all the people on the USS Enterprise would wear on their uniforms, their little to show that they were part of the Federation. And I thought that was cool. So if you're a sci-fi nerd like me, you might like to remember them as Star Trek insignia. So I give credit to Dr. Parker for teaching me that and many other cool ways to remember DermPath. So this is a fibrous papule, and it's totally benign. The one time that it might be kind of important is if you see a younger patient, like a child or teenager, with multiple reddish-brown lesions on the face, and on biopsy they all look kind of like this. In that setting, those are suggestive of tuberous sclerosis. So the lesions that are called adenoma sebaceum of tuberous sclerosis, they're neither adenomas nor are they sebaceous. So it's kind of the total misnomer. What they are is they're actually angiofibromas, and patients with tuberous sclerosis get multiple angiofibromas on the face, and they get a variety of other cutaneous findings as well as neurologic issues. So obviously I don't bring that up when I have a solitary biopsy from an adult where they're worried about a basal cell. But do keep in mind that if you have multiple little papules like this in a child, maybe talk to the dermatologist and make sure that there's no other signs that would suggest tuberous sclerosis. Usually that's pretty obvious clinically, but it's worth bringing up, and it's good for exams for residents and medical students to think of. Okay, let's do the next case. And this case was thought to be a basal cell carcinoma on the nose. And in fact, this is another example of a fibrous papule, not quite so robust as that last case. It's a little smaller, and this is probably what they look like more often. What you see here is there's kind of some dense dermal collagen centered around these couple hair follicles. And you might say, well, how do I know that that's dense dermal collagen? Well, look, we have a nice trick here. Look at this patient. This is what this patient's dermis looks like. Again, it's almost completely replaced. The pink collagen, normally what you'd see is this pink collagen like up here, but it's almost entirely replaced by this blue-gray solar elastosis. But here in the middle, that elastosis has basically gone away. It's been pushed out of the way by collagen. So in really badly sun-damaged patients who have a thick layer of solar elastosis, if you see a zone where suddenly the blue-gray elastosis goes away and is replaced with pink collagen, you should look at that area and ask, why is that collagen there? Is this damaged or biopsied or excoriated previously and now it's healed with scar? Is there a tumor nearby that's producing desmoplastic stroma? Or is there a fibrous lesion like a fibrous papule? So it's really useful. You can see this pink collagen here, and again, look over here, we've got elastosis, pink collagen, so you can tell there's really a lesion here. There's something has happened here to cause that. Go back here, back to elastosis. So this is a really useful trick to use in patients that have a lot of sun damage. So when there's not solar elastosis, you can't really use that trick. And then look here, we have dense collagen. It's kind of centered around follicles, and that's often what you see in fibrous papules. We've got dilated vessels. Let's look closer. Kind of these dilated telangiectatic vessels with bland endothelial cells, benign looking, totally normal endothelium. So just dilated vessels. There's a couple more over here. And then in the dense stroma, we've got those larger kind of funny fibroblasts. Now these aren't quite as stellate or as triangular as we saw in the previous case, but it just goes to show there's kind of a range of findings. It's really nice when they're big and stellate and triangular or star-shaped, but a lot of times they just kind of look like plump, round, spindled fibroblasts, kind of scattered here in this dense collagenous fibrotic stroma with these dilated vessels. And this is a little bump on the nose again, so that's the most common place. You can see them in other locations, but the nose is by far the most common site that I see them from. And it, again, got a little bit of that hypergranulosis and that stratum lucidum there that indicates that the patient's probably been rubbing or kind of picking or scratching at the lesion, and that's probably caused some irritation change. So that's another fibrous papule or angiofibroma if you prefer. And this patient had a second biopsy, and it was also thought to be basal, and lo and behold, it's another fibrous papule. This one looks a little different than both of the previous two. It's pedunculated, like the first example I showed you, but this one's notable because it's got very prominent telangiectatic or ectatic dilated vessels here. So you at first could even think, oh, this is a hemangioma or a little vascular malformation, cherry angioma, but the thing that sets it apart is that clinically it looked like a little pink pearly bump, like a basal cell, and unlike most capillary hemangiomas or cherry angiomas, whatever you want to call them, there's a lot more of a stromal component in between the vessels. So you don't just have dilated vessels like you might have in a telangiectasia or a vascular lesion, but what you have here is that dense collagen in the background. And in this case, you have, again, those kind of plump stromal cells, the fibroblasts, that are embedded in it. And they're kind of, some are spindled, some are kind of oval shaped. None of them are quite as triangular as that first example, but it's a really nice example. And here I think you probably have a kind of a funny cut of the endothelium. You're cutting right up against the edge. That's what that stuff is filling the vessel. Or alternatively, could be histiocytes in the vessel. You can see both those things. So usually a funny cut of a vessel wall can sometimes make it look like there's a bunch of cells in there, but you're actually just kind of skimming against the backside of the lining of the vessel. And there's a little inflammation here. Those little small dark dots, those are lymphocytes, of course. And you can get inflammation in your fibrous papules. So there's a nice example of another fibrous papule, and here kind of as we get to the edge of it, it's a little less prominent and kind of looks just like, more or less just like telangiectasias. But when you go on this area, you can see the fibrosis there, the larger kind of spindled fibroblasts in the background, and the dilated vessels centered around hair follicles, making a little bump on the nose. Fibrous papule or angiofibroma. Okay, let's look at the next case. We'll shift gears here. And when you're looking through a tray of DermPath slides, that's often what you have to do. You'll go from one type of lesion to a totally different type of lesion and back and forth. And you have to learn to be able to shift the way you think between cases. That's, I think, to me, part of the fun of DermPath is the wide variety of things you see every day. So this was a kind of fleshy, pedunculated or kind of raised lesion on a patient's, I think it was somewhere on their scalp. And this lesion is a really nice example of congenital pattern nevus. So this is an intradermal nevus, or mostly intradermal at least, and you can see this is raised. It was fleshy and flesh-colored clinically, and you can see there's a bunch of increased cells here in the dermis. And so I know from low power you might say, well, I can't tell that those are melanocytes, but after you do enough DermPath, or any pathology for that matter, usually from very low power, you can, from the silhouette, Dr. Ackerman, a famous dermatopathologist, liked to talk about the low power silhouette of lesions, and that's a really important clue to being able to figure out what the diagnosis is by looking at the kind of overall shape of the lesion from low power. And I totally love that approach, that low power, look at the lesion and try to figure out what it might be, and then you go down to higher power to confirm it. So in this case, you can see, you know, from low power, you might first pick up on these big sebaceous glands, and you might think, oh, this is something to do with sebaceous glands. But those are just actually kind of a reactive increase in sebaceous glands that you sometimes see over top of nevi. And these kind of long, thin strands coming down, those are just elongated, reedy ridges or elongated portions of follicles. Again, it's a reactive epidermal change that we sometimes see over nevi and over other entities like dermatofibromas. It's kind of related to what we call follicular induction. It's a kind of a reactive process where hair follicles and skin surface grow because of something in the dermis. So let's look down a little closer and see how do we prove this is a nevus. Well, when you look at the cells up here that are filling the superficial portion of the dermis, you can tell that they're kind of gray in color, and they're arranged into little clusters. We call those nests. When you see gray cells that are clumped together in nests in the dermis or epidermis, that means you're probably dealing with a melanocytic lesion. There are some other things that can nest, but in the skin, when you see nests of cells like this, the first thing you should think of is either nevus or, in the right setting, maybe melanoma. We're not going to talk about melanoma today. It's a bit too complicated for this video and kind of requires some more time. But these nests of cells, these are melanocytes. Let's look a little closer. They have kind of round or oval nuclei, and they sometimes will have small kind of dot-like or punctate nucleoli in the center of their nucleus. And they have gray to pink cytoplasm. Sometimes you can have a little bit of brown melanin pigment, but a lot of times the cytoplasm is totally devoid of any visible pigment. That might be kind of surprising if you haven't done DermPath yet to think, well, melanocytes make melanin pigment, why aren't they pigmented? But oftentimes they're not pigmented. The job of a normal melanocyte is to make pigment and feed it to the neighboring keratinocytes. So a lot of nevi don't have a bunch of pigment in them. And the other thing that you should know about melanocytes is that sometimes they like to cluster together and make little multinucleated cells. These can look kind of similar to multinucleated giant cells, but these are actually not histiocytes or giant cells. These are actually just clustered melanocytes kind of fused together. The reason it's important to know about those, you often see those in benign nevi, particularly big congenital looking nevi, but from low power, sometimes those cells can really catch your eye. They can look really dark and big, and so you might think, oh, it's a pleomorphic atypical nucleus, and you might inadvertently start thinking that this is a malignant lesion because it looks big and dark from low power, but at higher power, you can realize, oh, it's actually just a bunch of nuclei all closely associated with one another. So these are nests of melanocytes, okay? Now, the next thing I'm going to show you here, and again, we can't really go into the full spectrum of melanocytic lesions today, but is when you have a nevus, the typical feature of nevi, and you can see this really well in these big, thick nevi, the congenital pattern nevi, is that when you go from the top, you start with large, plump epithelioid melanocytes that have a lot of cytoplasm and are arranged in nests. And as you go deeper, the idea is that the melanocytes get smaller, they have usually less cytoplasm, and they tend to have smaller nests or even trickle out into little single cells or even little spindled, elongated cells the deeper you go into the dermis. And we call that pattern maturation. So let's see, we're starting with these larger nests up here, and as we go deeper, look what happens. The cells are still there, but they're a bit smaller, and now instead of them being in nests, they're trickled out as little single cells that are kind of scattering out into the dermis. And that's perfect. In a lot of tumors, when you see little single cells scattering out, you start thinking, oh, it's infiltrating or invading. That's a bad sign, like for a lot of epithelial tumors. But in melanocytic lesions, this is totally a normal pattern. It's a good pattern. It's a reassuring pattern usually when you see the cells get smaller and become single and kind of trickle out into the dermis and in between dermal collagen bundles that or have like little tiny nests as you go down. And most of the cells, there may still be some larger cells here that have a lot of cytoplasm, like these guys over here, but a lot of them are much smaller than the cells that we were looking at the top of the lesion. So getting smaller nests and smaller cells as you go deeper, that's called maturation, and that's a normal pattern in nevi, intradermal nevi and compound nevi. And also I'll point out, a lot of times melanocytes have these little vacuoles in the nucleus. They're called nuclear pseudo-inclusions. They're not actually a full vacuole. What they are is a little, sorry, I'm going to get it centered here, a little blob of cytoplasm. See how the color is kind of gray, just like the cytoplasm outside? What this is like a little blob of cytoplasm that's pushed into the nucleus, and then when we cut through the nucleus, it actually looks like it's a little bubble there, but it actually is a bubble that connects back out to the cytoplasm. Imagine if you take a balloon and push your fist into it and kind of invaginate into there, it makes like a kind of cup shape, and then if you were to take in 3 dimensions and cut right through that, what it would look like is a circle in the middle of the balloon, but it's actually not a full vacuole. So anyway, these nuclear pseudo-inclusions you often see in melanocytic lesions, both in nevi and also sometimes in melanoma. So they don't always tell you that much by themselves, but I think it's worth noting that they're often there, and if you see them and you're a beginner and you wonder, what's that cell? Well, now you know. Nuclear pseudo-inclusions in melanocytes. Okay, so this nevus is a normal benign looking nevus, and when nevi trickle way down deep into the dermis and track around sweat glands, or excuse me, sweat ducts, or around hair follicles, or around blood vessels or nerves, we call that a congenital pattern. Now, that doesn't mean that the nevus was definitely there when the person was born, but when we see nevi in babies, in nevi that babies are born with, we often see those features that the dermal melanocytes track way deeply into the dermis and surround the normal structures. And to me, that makes me think that this nevus kind of grew along with the person's skin embryologically. I don't know if that's exactly how it happened. I'm sure there are people that are skin biologists that understand in great detail the embryology of the skin, but the way I imagine in my mind, and it makes it easier to remember, is that these melanocytes kind of grew up as the skin was developing in the baby. So they'll get intermingled with all the normal skin structures. You can even see them infiltrating into the middle of erector pili muscles and unusual things like that. And those are kind of signs that we often see in congenital nevi. And I don't think this case really shows it, but sometimes the cells, well, this shows it a little bit, I suppose. Sometimes as you go down deeper, the shape of the cells changes from the round cells with cytoplasm, or what we call epithelioid-looking melanocytes, to kind of more elongated, spindled looking melanocytes. And they can become so spindled, in fact, that they look very much like that neurofibroma we showed earlier in the video. And look, there's a little mast cell right here. So actually you can get very spindled, or what we call neurotized nevi, that look just like a neurofibroma. They can be at high power, they can be almost identical actually. So again, that's why low power helps you. If you see nests of melanocytes anywhere in the lesion, it's probably a nevus and not a neurofibroma. Both are benign, and the distinction rarely matters clinically, but I think it's useful diagnostic pearl to know. So here again, from low power, a nice example of an intradermal nevus from the scalp of a patient. All right, let's move on to a different case. And here's a red, scaly, growing lesion on the skin of a sun-damaged patient. And it's kind of cup-shaped or crater-shaped, and it looks like almost like a little volcano with a bunch of pink keratin coming out of it. So whenever you see a cup-shaped lesion with a lot of keratin coming out of it, in sun-damaged skin on an older patient, you always have to think about squamous cell carcinoma. And there's another entity called keratoacanthoma, which some people believe is benign and some people believe is a variant of squame. I personally tend to regard it as a variant of squamous cell carcinoma, but that's a more complicated and controversial topic than we're going to discuss here. But in any case, I think that whenever you see this cup-shaped kind of a lesion filled with keratin in sun-damaged skin, always stop and think, could it be squamous cell carcinoma? Because if you look here, there's not much that's very atypical, right? This the surface looks actually kind of lichenified and reactive. The patient's probably been scratching it. See that really thick band of purple keratohyalin granules? That's the clue that it's been scratched and rubbed. And there's not much atypia in the cells. And as you go down, look, the nuclei don't look very bad at all in these cells. These are keratinocytes. How you know they're keratinocytes? They're coming off the epidermis. They have a abundant bright pink cytoplasm. And look, at high power, look what you can see. See all those spines? Those are desmosome spines that are holding the keratinocytes together. A really beautiful example here. And those spines and the dense pink cytoplasm, characteristic of keratinocytes. Now look, these are keratinocyte nuclei that have some nucleoli, which is normal for keratinocytes, and a lot of cytoplasm. They don't really look very ugly or atypical, but they do have a bunch of pink cytoplasm. So when we see that really abundant, dense pink cytoplasm in keratinocytes, we say that they look kind of glassy. And when I see a proliferation of glassy keratinocytes in sun-damaged skin, oftentimes that ends up being squamous cell carcinoma. So I think it's really important to recognize that you're looking kind of at a different sort of feature, where a lot of other tumors you look for nuclear pleomorphism and atypia, and you can see that in squamous cell carcinoma also. But to me, I think you also have to look out for these very bland lesions that don't have much nuclear atypia, but have this real glassy cytoplasm. And also look at the growth pattern. This is really pushing down into the dermis. And look what happens at the bottom of the lesion. It trickles out in little nests of invasion that are invading into the dermis. So up top, when you have a superficial shave biopsy, these lesions are often very difficult to diagnose. And that's why if I see kind of a crater filled with keratin, if I can't see the bottom or anything definitively to make a diagnosis of squame, I'll often put a comment in that, hey, this lesion has some features that worry me that there might be a squamous cell carcinoma underneath. And then the dermatologist can decide how worried they are, and they can either go back and repeat biopsy the lesion or do some additional work on the lesion, or they can follow the patient closely and see if the lesion goes away or comes back. But I like to at least alert the dermatologist that I have some concern that there could be a squamous cell carcinoma. This biopsy, they were clearly worried about it, and they got a nice deep shave biopsy, and we can see that down at the bottom what we have is more atypical cells. The nuclei are more atypical, and some mitotic activity in there. There's a mitosis here, which you can have mitoses in benign squamous lesions too. But this growth pattern, these really angulated, irregular nests invading the dermis with nuclear pleomorphism. And here, look, this little nest is making a little ball of keratin with some retained nuclei. So this is kind of what we call squamous pearls. They like to talk about that in med school. And this is a squamous pearl. Not the best one maybe, but I think it works in a invasive squamous cell carcinoma. Here, actually this might even be better. This is kind of a squamous pearl too, where the keratinocytes are kind of getting glassy and making a little swirled nodule in the middle of a nest. But look at this invasive kind of angulated pattern. Again, I think from lower power it's easier to see the invasive trickling growth here. and this is squamous cell carcinoma. But I think it's important to point out that the crater-shaped keratin-filled area, and how on a shave biopsy that can easily be mistaken for a cyst or something benign. See over here, it doesn't really look that atypical, but that pattern of kind of complex cystic growth, glassy keratinocytes pushing down into the sun-damaged skin always worries me. Right away, the first thing I think of squamous cell carcinoma. And then look over here. I mean, here, there's really not much at all to suggest squamous cell carcinoma. The epidermis looks very reactive and very thickened with a thick granular layer. This is actually very similar to what we call prurigo nodule or lichen simplex chronicus, which are two kind of variations of the same thing, reactive thickening of the epidermis from chronic scratching or picking or rubbing of the skin. And this makes sense. We often see this change right next to squamous cell carcinomas or other skin cancers because the lesions are irritating as they invade the dermis, and then the patient feels pain or discomfort, and so they scratch and pick at the lesion. So we often, very often, I would say almost always, in fact, see reactive changes in the epidermis next to a squamous cell carcinoma. So that's why it's really important. If you've got a big biopsy and you can't really see all of it, maybe do deeper levels and look right here, actually. If we look closer, it's very focal, but we can see the squamous cell carcinoma. It's right there. Sorry, let me get in focus here. There, see those invasive little islands there and there. So at the top, it doesn't look like much. It looks very reactive. And again, that's why I'm always very careful with warty or prurigo nodule or seborrheic keratosis-like lesions that are kind of glassy, and where if the biopsy's thin and I can't see the bottom, I always think, well, could there be a squame that we're not seeing underneath? Because I feel like we often see this particularly in the sun-damaged skin on the extremities. Squamous cell carcinomas often have that more glassy look and are not the really wildly atypical things that we sometimes see in other sites. So on the lower leg or on the hand, the dorsal hand or the distal arm, this is the kind of squamous cell carcinoma that you'll often see. So this is bread and butter dermatopathology, what we look at every day. Let me show you another example. Here's another one. It's crater-shaped, cup-shaped. In this view, very similar to what a lot of people would call keratoacanthoma, because it's kind of got smoother borders and it's got the glassy keratinocytes and is pushing down in. Sometimes lesions that have this kind of keratoacanthoma look, this cup-shaped, crater-shaped look that don't have real marked atypia, some of them regress on their own. And that's why there's this belief that maybe they're different than squamous carcinoma, that they kind of regress and go away on their own. And while I certainly see that happen, I've seen other ones that look kind of like this that do progress and still continue to grow like a cancer. So I feel like to me it's safest to usually consider them as squamous cell carcinomas for the purpose of follow-up and treatment. But again, that's just my opinion. There are other dermatopathologists that disagree with that, so I'm going to admit to you right now that there are different schools of thought, and you can go and learn those schools and then decide for yourself which school you want to follow. And then over here you can see there's kind of more obvious islands of invasion, but again, look at the pattern is invasive from low power, which is what tells you that you're dealing with a cancer. But look at the cells. They don't have much nuclear atypia, but they have that really dense, glassy cytoplasm. Really abundant, dense pink cytoplasm, and you got some parakeratin formation. So when you have little whorls and nodules of parakeratosis where the nuclei are retained in the keratin, way deep down in a pushing or invading squamous lesion, that's a really good clue that you're probably dealing with a squamous cell carcinoma. It's not a hard and fast rule, but it's a clue that when I see little nodules with nuclei retained, that means that this lesion is probably kind of growing quickly, and the kind of pattern of keratin maturation is abnormal, and it worries me that we're dealing with an invasive squamous cell carcinoma, which is exactly what we're dealing with here. So most squamous cell carcinomas of the skin, if they're treated when they're smaller, are usually have a good prognosis, and as long as they're treated appropriately, the patients do fine. But if you have squamous cell carcinoma on the ear or the cutaneous lip, those have a somewhat higher risk of giving rise to metastases. So you can have sometimes aggressive squamous cell carcinomas of the skin, but usually with appropriate treatment, the prognosis is quite good. All right, and let's see another case here. All right. Now here's another lesion on sun-damaged skin. And note that there's a kind of a glassy pink keratinocytes here. So you could think, well, maybe this is squamous cell carcinoma. But in this case, actually, again, at high power, it's almost impossible to tell this apart from a squamous cell carcinoma. But when you go to lower power, the clue is in the shape. Look at this lesion. It's kind of mounding up from the skin. And if you took you could take a line and draw a line directly underneath it, straight underneath it. It's got a straight, kind of flat bottom. You could draw a line right under it. This is in fact a seborrheic keratosis. See, these are kind of, it doesn't have well-developed horn pseudocysts, but these kind of little pockets full of keratin are kind of analogous to the horn pseudocysts. They connect up to the surface, and you can see a few of them look kind of cyst-like here. All right? And look, there's this really brisk, dense band of inflammation here. These are all lymphocytes. And the lymphocytes are kind of attacking the lesion, and it makes the lesion look more atypical when you see that. And look what's happening. If you go to closer, you can see there's actually kind of a lichenoid pattern of inflammation, a dense band, and then there are little pink dying keratinocytes in there, which are kind of similar to the cytoid bodies or apoptotic keratinocytes, dyskeratotic keratinocytes. There's lots of different words for this, but these little dying keratinocytes and these little bubbles and vacuoles along the basal layer, those little bubbles right there, this is called interface change. So we see that in lichen planus and a lot of inflammatory dermatoses, but you can see that exact same pattern of lichenoid inflammation underneath keratinocytic lesions that are being attacked by the immune system, particularly seborrheic keratoses and lentigos and other things like that. So here at lower power, again, the flat bottom helps us. And the fact that even though it looks kind of glassy and a little atypical down at the base, if you look up at the top looks nice and has a lot of orthokeratin. It doesn't have a lot of parakeratosis on it usually. And again, the overall shape of the lesion is what tells you this is a seborrheic keratosis that's inflamed, not a squamous cell carcinoma. Admittedly, I still, on an almost daily basis, struggle with lesions like this if they're not biopsied deep enough. I will sometimes have trouble telling an inflamed irritated wart, an inflamed seborrheic keratosis, and a squamous cell carcinoma apart. And I've been doing DermPath for a few years now, and I've been trained well in it, I think. But it's still something that, even though it seems so basic, it still ends up being difficult because the lesions can have a lot of features that overlap with each other. So that just takes a lot of practice, but it's good to know that those lesions can be troublesome even for people who see lots and lots of skin biopsies every day. So this is an inflamed seborrheic keratosis. And then for the final lesion, this is something that clinically was thought to be a skin cancer. It was a red, irritated, painful lesion with a ulcer and crust on the surface. And see that thick layer of purpley pink stuff? That's what scab looks like microscopically. It's called scale crust. It's a mixture of parakeratosis and serum and neutrophils and probably some bacteria too. So this lesion doesn't actually have anything here that looks like squamous cell carcinoma, so clinically it was worrisome. But when we look microscopically, what we see is there's a big ulcer of the epidermis. So we have to wonder, why is the ulcer there? Well, it's hard to say at first glance. The clue is down here in the dermis. There is an ulcer, and there's all that, the scale crust, like I said. There's serum, the pink stuff. The little dark things are degenerated neutrophils. These little purple blobs here are actually cocci bacteria, probably staph organisms that are staphylococcus that normally grow in the skin as flora, are just kind of colonizing this lesion. We often see that in the surface of ulcers in the skin. But the key is in the dermis. In the dermis, we have really dense lymphocytes around the superficial vessels and also even around the deeper vessels. And not only do we have lymphocytes, but we also have lots and lots of these bright orange little guys with orange granules. These are eosinophils. So there are tons of eosinophils in here. We have a bunch of lymphocytes and then bunches of eosinophils. And the eosinophils aren't just up at the top, but they go deep down into the dermis. Oops, sorry. They go deep down into the dermis. They gotta go out away from the vessels in between the collagen. Let's look at the other piece. Even away from the ulcer, we see the same thing. eosinophils. So this is actually probably an exuberant bug bite, a bug bite that got really inflamed and the patient scratched and itched at, and then it ulcerated, and then it got bacterially infected or impetiginized, and it made it look even worse. And so when they came to the doctor, they might not even remember that they got bit by a bug or even known it. All they know is they had this itchy, painful lesion, and they kept picking at it, and then it kept getting worse. And so they came in, and the dermatologist said, let's make sure it's not a skin cancer, and biopsied it. And we see that often, that a bug bite that's really exuberant can look a lot like a skin cancer clinically. So usually what I call these is arthropod bite reaction. Some people like to say arthropod assault reaction because that covers both bites and stings. I think that's kind of a fun way to say it, but I usually just say arthropod bite reaction. And it's a good thing to know about because we see a lot of them in my part of the country. We have lots of insects here, and a lot of times people get bug bites. And people that can particularly get really inflamed, exuberant bug bites are young kids around the age of 2. Their immune system's kind of still developing and learning to react to different things. And sometimes they get really big, really inflamed bug bites. And also in older individuals with chronic lymphocytic leukemia, CLL, for some reason, because their immune system is altered, they also tend to get really exuberant bug bites. So those are some random basic derm path cases, and if you learn something new from every case, you'll eventually be an expert.